endoscope, which is the device that we use to view, visualize, inspect the ear whilst we're removing the wax. And we also have an online website where if you're in the UK, you can enter your postcode or city or town and to find and locate your nearest earwax removal specialist. So I've decided to do a quick compilation of 3 patients today. This is the first patient, and this is the patient's right ear. And you can see the wax is quite glutinous, it's quite sticky. The patient had been using, I believe, some hydrogen peroxide drops prior to attending. I do find that hydrogen peroxide drops have this effect on earwax. It makes it quite mushy, almost like mashed potato, which therefore makes it quite difficult to suction. So I think in a moment I'm going to try and change the consistency of the wax. You can see how blocked it is. It's fully occluding. It's really completely created an airtight acoustic seal around the ear canal. So I've just instilled some olive oil earwax drops, and immediately it's changed the consistency of the earwax. It's not blocking the tube, the suction tube for one, or not blocking it as much. And what the olive oil would do, it almost binds the wax together. I always compare olive oil and the effect it has on earwax to how an egg helps to bind up all the ingredients if you're making a fish cake or potato cake, which is great because the quicker we can remove the wax, the better for the patient, obviously the better for myself as well. It's not as always easy, even if you do fill up the ear and soak the ear with olive oil for hours, and well, not hours, but I've done it before for about 20 minutes with a patient. Sometimes it still doesn't work and we just have to get the patient back, but that's quite rare. So I would say probably 1 in 50 I have to get back for a second appointment, which is quite a low rate really. So it's 2%. There we are, I've got all the wax out. You can see the tympanic membrane, the eardrum, just some residual wax on the anterior canal wall, so that means the front part of the ear canal. Just have to be very delicate, so it's a bit of skin actually, a bit of keratin that's oxidizing, it looks like earwax. Just have to be really delicate, just want to really avoid touching, making direct contact. The eardrum's visible, so posteriorly the eardrum, there's some dead keratin that's forming on the eardrum. You can see a yellow patch. That's fine, that will naturally shed. Again, I'm just mopping up near the entrance. All this, it's not really going to improve the patient's hearing per se, but it's right lateral, so it's on the cartilage portion of the ear canal, so I can put a bit of pressure against it. If we were doing this on the inner 2/3 of the ear canal, so before you saw I was delicately and gently removing some dead keratin off the canal wall, that was more on the bony part. We wouldn't be able to remove that in the same way. I just removed this lateral piece of wax. So that's the first patient. This is the second patient. I forgot which patients are which now. So this is the one I literally just saw an hour ago. Lovely gentleman, lives local, been recommended. He used to get his wax removed at the hospital using microsuction, but he's obviously come across myself. So this is the patient's left ear. He had been instilling some drops, some softening agents. I think he was using olive oil, but despite that, it's a real big plug. You can see the dead keratin. If you really look carefully at the ear canal, just around the perimeter where the wax is, you can see this white spongy layer. You can see as I'm trying to remove this wax, this white layer, it's almost oozing out olive oil because it's been soaked quite a lot. That's dead keratin. So that keratin has adhered to the wax and it's also adhered to the ear canal wall. You can compare it to double-sided sticky tape, which always makes the procedure a bit more tricky. And within the ear canal, you've got 2 bends. You've got the first bend, which is probably about 1/2 centimetre into the ear canal, and then you've got a second bend, which is between 1 centimetre and 1/2 centimetre. This wax is lodged beyond the second bend. I'll try and endeavour to put a picture of a cast. I've got a really good one actually I took a few weeks ago of the anatomy of one's ear canal, because it's not always visible when you're removing earwax. So I will upload that and you'll see sometimes the second bend can be almost 90 degrees. So this wax is lodged behind that bend. So I've decided to go in with an ear hook. The patient was finding this a bit uncomfortable, and it was just purely because how lodged this wax was and how hard it was. And you can see I wasn't making any contact with the canal wall but he was finding it slightly, he was happy for me to continue. The alternative was just to carry on vacuuming, and I don't think that was going to really remove this wax. So, well, I've just shredded this bit, so I'm just trying to remove this, but you can see even with the Zollner suction probe here, I've loosened this wax, it isn't coming. So in a moment, I was trying to avoid the ear hook again because he did find it slightly uncomfortable. So I went in with some forceps, but the forceps really weren't cutting the mustard either. So at the end of the procedure, I had no choice really but to put the ear hook in, and we did get the wax out in one big lump. But the dead skin, as I removed the plug of wax, some of this skin, the layer of skin, has also become detached from the canal wall, and you'll see blistering. So there was no active bleeding, there was no cut, we didn't cause any trauma ourselves. It's just the physical removal of the wax and the keratin that came out with it. The keratin detached from the canal wall, and it just left blistering, that's sometimes happens in ear wax removal, but it wasn't any direct trauma caused by ourselves. And you'll see, so I think here we are now, we're in with the ear hook. So I'm actually inserting the hook anteriorly, so to the left hand side, to the front of the left ear canal. And as I'm removing this, you'll see I'm nowhere near the back canal wall. The ear hook is more in the middle and to the front, and we're near the entrance. I'm bringing this out, so I did not make any contact with the back canal wall, but you can see that's where the skin detached from. So the ear hook was nowhere near that. And there's no cut there, it's just basically skin that detached. It's more blistering than bleeding. Just realised I'm really having to defend myself, aren't I? Because just probably because some of the comments I receive. I shouldn't really have to do it, but anyway, there we are where we are. So yeah, the eardrum's nice, visible, healthy. This is the patient's, same patient but just the right ear. You can see a plug of wax here. It's not as impacted as the left side, so the patient did attend, he wasn't aware that his right ear was even blocked, given his left ear was so bad. So it was only until I removed the left plug of wax, he suddenly noticed that his right ear wasn't as good. So I'm just loosening this. Again, he's got a lot of dead keratin, you can see that, the white coating. So I've just got him with some forceps. There was enough give. There wasn't this plug wasn't too soft, because otherwise we'll just be dissecting it. It came out in a big chunk. Just some dead keratin again. Just going to mop up near the entrance. So just using a fine end gauge to stop it clarinetting. Again, I mean, we could have just left the procedure like this, but I just wanted to remove this dead skin, because this part of the dead skin anyway is ready to be peeled. But as we go towards the eardrum, the skin was a lot more stubborn, and there's a bit of a tug of war. I did ask the patient whether he was okay, whether it was uncomfortable. He said it was fine. There was no clarinetting because I used a fine end, so the patient was really unaware what I was trying to do in the ear. He didn't feel anything at all, but there was a bit of dead skin that we left behind despite my best efforts again. So it may look easy on a video, or just a bit of skin there, why don't you just pull it out? Well, it's not as easy as that, believe you me. So we're really tugging away, but I did give it a fair crack. Got the majority of dead skin out. I even used some forceps to see if I can yank and pull, not a very good technical medical word, but extract and pull, but yeah, to no avail. So again, we're really close to the eardrum, so we have to be really gentle here. We're on the bony part. So again, if we make contact with this bony part of the ear canal, this patient won't be very happy, and he probably won't be coming back here. So this is where you need great hand-eye coordination, control of the endoscope. I mean, we do train a lot of, we're just looking at some of the data yesterday. I think we train in excess of 250 specialists, both in the UK and abroad. And despite people's best intentions of really developing the skill, there is going to be some people that no matter how much training we provide, they're just not going to have the skill level to do this, unfortunately. And because again, although you need the audiological knowledge to perform this procedure, you do still need the hands-on practical skills. And I can imagine some people who are good at gaming, for example, who have got really good ambidextrous hand-eye coordination. Okay, they lack the knowledge of the ear, but if they were doing this on a mannequin, for example, where they've got no risk of causing injury, that there might be some of these gamers would be really, really good. So just going with some forceps. These are the fine end shaft 5mm forceps because we're going quite deep. And again, pulling at it, it's not ready to come out. So after this last attempt, I just left it. It's not going to cause the patient any problems. Got the majority of the dead skin out. Lovely, healthy tympanic membrane, good light reflex. You see the incus, which is commonly known as the anvil, which is the second of the middle ear bones. There's the remnant, so it's just weighed in at under 0.5 gram, so 460 milligrams. And this is to the last patient. This is quite a quick one, just thought I'll add it in there, otherwise this video will be surplus to requirements because I wouldn't be uploading a short video like this on its own. So this is the patient's right ear. Patient had been using some drops that came up really quickly and easily. Been using some olive oil drops, I believe, some dead keratin there. I'm just going to mop up, and again, lovely healthy eardrum. And then we're going to switch to the left side. So this side, the patient hadn't been using any drops. The wax is a bit stickier, drier. So it's a bit more of a, I need to tug this. A few cilia, which is slightly obscuring the view, but still safely remove this. So just, you can see the consistency, the difference. This is really a sticky, gluey type of substance. Just releasing it from the canal wall. This is probably midway into the ear canal, so what people have to realise, the ear canal is not straight, so the diameter of an ear canal is between 6 and 8mm, give or take, for the majority of people, and the ear canal is not a straight line. You've got two distinct bends. The second bend can be 90 degrees sometimes, so we're not only having to enter a very small chamber, a very small orifice. Remember that the Zollner suction probe is 2mm diameter. The endoscope is 2.7, so that's for almost 0.5 centimetre already, so 0.5mm already. So we've only got a couple of millimetres here and there, give and take, and then the ear's bendy, so we have to stretch it, widen it, almost like we use the instruments as it's like a crowbar to widen the ear. Anyway, guys, I need to wrap this up, so I've got to get home. It's a bit late now, but I hope you enjoyed that video. If you're watching on YouTube, please do subscribe, select the bell icon, so you'll get notified as and when I upload new videos. If you're watching on Facebook, Instagram, please do follow the page, like the video, leave a comment, and